Spring 1945. At a U.S. Army processing center in Europe, an American medical officer calls for the next German prisoner. He expects standard combat trauma, shrapnel wounds, or severe trench foot. Instead, a young female German military auxiliary steps into the tent. She has no battlefield injuries. She is suffering from advanced systemic starvation. It is a level of severe physiological collapse the doctor anticipated finding only in liberated camps, not among active enemy personnel. To understand why a uniformed soldier of the Third Reich was quietly starving to death, we have to look behind the front lines and into the collapsing veins of the German war machine. This single medical examination shatters the enduring myth of the meticulously organized Wehrmacht. It reveals a hidden, parallel war fought not with artillery, but with calories, crumbling infrastructure, and a rapidly disintegrating supply chain. For American field hospitals tasked with processing thousands of newly captured prisoners in early 1945, this presented an unprecedented crisis. They were equipped to patch fresh combat trauma, not to arrest the profound, systemic malnutrition of enemy support staff. How does a military apparatus, historically obsessed with rigid logistical doctrines and administrative efficiency, deteriorate to the point where it functionally starves its own uniformed female personnel? The answer lies far beyond the immediate battlefields. This biological collapse did not materialize overnight. It was the terminal symptom of a cascading national failure that began months earlier, a crisis originating high in the contested skies over Europe and buried deep within the increasingly desperate ledgers of German quartermasters. By the winter of 1944, the structural integrity of the German supply chain had been methodically dismantled. Following months of relentless Allied strategic bombing campaigns targeting marshalling yards, synthetic oil plants, and critical rail hubs, the Deutsche Reichsbahn, the massive railway network serving as the primary artery of the Third Reich, functionally collapsed. Locomotives were destroyed faster than they could be replaced, and severe coal shortages left surviving transport trains stranded indefinitely on rural sidings. Without a functioning railway, moving bulk agricultural yields from the eastern territories to the industrial west became mathematically impossible. The entire national logistics grid fractured into isolated, localized pockets. Faced with this catastrophic constriction, German quartermasters were forced to implement a ruthless system of caloric triage. The remaining, fiercely guarded trickle of provisions was strictly prioritized for active combat infantrymen and panzer divisions facing the immediate Soviet and Allied advances. Everyone else was systematically downgraded. Administrative clerks, communication specialists, and the tens of thousands of female auxiliaries, the Wehrmachthelferinnen, who operated the anti-aircraft batteries and telephone exchanges, found themselves pushed to the absolute bottom of the rationing hierarchy. Officially, they were active military personnel. In reality, they were being administratively starved by their own high command to preserve the shrinking fighting corps of the army. Across the shattered front lines, the advancing United States Army presented a stark logistical contrast. The U.S. Army Medical Corps was operating what was arguably the most sophisticated, well-supplied military health system in human history. American field and evacuation hospitals were highly standardized, mobile units that moved closely behind the advancing armor, pulling heavily laden supply trucks packed with revolutionary medical technology. These units were meticulously equipped with vast quantities of penicillin, standardized surgical kits, sterile blood plasma, and newly developed sulfa drugs. American medical doctrine was a rigid, highly efficient system built around one specific, predictable profile: the acute mechanical trauma of a previously healthy, well-nourished young male. The entire chain of medical evacuation, from frontline medics to battalion aid stations to rear area general hospitals, was optimized to treat penetrating shrapnel wounds, high-velocity gunshot injuries, severe burns, and the environmental ravages of trench foot. The doctors and corpsmen manning these clearing stations were essentially mechanics of the human body. They were rigorously trained to stop catastrophic bleeding, excise necrotic tissue, prevent infection, and stabilize patients for rapid transport. They were not, however, equipped to function as emergency nutritionists. The standard field manuals and medical protocols of the era contained virtually no guidelines for managing systemic, prolonged starvation in combat zones, let alone dealing with the complex, often fatal metabolic dangers of refeeding syndrome. When the German defensive lines finally collapsed in the spring of 1945, these two opposing realities collided in the processing centers. Allied forces did not just capture retreating infantry, they overran the entire, disintegrating administrative rear echelon of the Wehrmacht. Suddenly, American medical tents designed exclusively to process acute combat trauma were flooded with a wave of chronically malnourished prisoners. The U.S. Medical Corps found itself facing a biological crisis it had neither the training nor the specific logistical framework to handle. They possessed mountains of antibiotics and surgical tools, but this advanced equipment was entirely useless against the slow, silent degradation of human tissue caused by months of severe caloric deprivation. The American triage system, accustomed to categorizing patients by the severity of their bleeding or the shattered state of their bones, struggled to quantify the invisible, internal damage of a starving enemy soldier. It was within this unprecedented logistical friction that the true human cost of the Reich's collapsed supply lines became undeniably visible. When the American doctor began his routine physical assessment of the female prisoner, the medical charts revealed a terrifying timeline. As the stethoscope pressed against the prisoner's chest, the first clinical anomaly was the heart rate, bradycardia, a dangerously slow, weak pulse that was fundamentally inconsistent with the high adrenaline and stress of recent capture. Moving through the standard physical assessment, the American medical team began documenting a disturbing catalog of symptoms that defied their frontline experience. There was profound, visible muscle atrophy. Her body had long ago exhausted its fat reserves and had been cannibalizing its own skeletal muscle just to maintain basic central nervous system and organ function. The doctors noted severe edema, fluid pooling heavily in the lower extremities, which is a classic hallmark of prolonged critical protein deficiency. A closer examination of her oral cavity and skin revealed advanced vitamin deficiencies, bleeding gums indicative of early scurvy, and chronic, opportunistic skin infections that her heavily suppressed immune system could no longer fight off. For the attending physicians, the diagnostic picture was mathematically clear. This specific physiological devastation could not be explained by a few chaotic weeks of retreat, a disrupted supply convoy, or getting cut off in the woods without field rations. The human body does not deteriorate to this cellular level of starvation in a matter of days. The deep tissue wasting and severe metabolic suppression recorded on her medical chart proved undeniably that she had been systematically deprived of fundamental baseline calories for a minimum of 4 to 6 months. She had been slowly starving to death while actively in uniform, operating within the administrative framework of the German military. For the American medical staff, the reality of their mission suddenly shifted. They realized they were no longer simply treating the acute, localized wounds of combat. They were staring at the biological footprint of a completely destroyed enemy infrastructure. This woman was not an isolated case of unit-level neglect. Her failing body was the physical manifestation of a collapsed national logistics grid. The realization forced a chilling tactical question. If this was the documented condition of an active-duty military auxiliary, what exactly was happening inside the Wehrmacht's supply chain? To find the answer, the American doctors knew that blood tests and clinical observations would not be enough. They needed to look beyond the medical tent, straight into the captured ledgers and supply manifests of the enemy quartermasters. The answers were waiting in the abandoned command posts and shattered rail cars scattered across Western Germany. As American military intelligence officers and medical administrators sifted through captured Wehrmacht quartermaster ledgers, a chilling administrative reality emerged. The documents revealed a bureaucracy that had meticulously and consciously engineered the starvation of its own personnel. In the final months of the war, the German High Command had formalized a brutal system of logistical triage. The rationing hierarchy, governed by strict categories known as the Verpflegungssätze, was ruthlessly enforced. At the very top were the frontline combat troops, the panzer crews, the active infantry, the units attempting to hold the crumbling defensive perimeter. They were allocated the absolute maximum of whatever calories the dying Reich could still harvest or transport. But as the transportation network failed under Allied bombing, there was simply not enough food to sustain the massive administrative apparatus that supported the army. Instead of distributing the deficit equally, German logisticians made a cold, calculated decision. They explicitly severed the supply lines to their own rear echelon support staff. The captured orders demonstrated that female auxiliaries, the Wehrmacht Helferinnen, operating telephone exchanges, managing telegraph networks, and crewing the searchlights of anti-aircraft batteries, were systematically downgraded to the lowest possible rationing categories. These women were essentially reclassified on paper from vital military personnel to expendable liabilities. Month by month, their caloric intake was deliberately reduced by the central planners in Berlin. The ledgers showed a steady reduction from standard military rations to meager civilian allowances, and finally to a near-famine baseline. The High Command knew with absolute scientific certainty that these reduced caloric allocations were insufficient to sustain human life over an extended period, especially for personnel performing demanding physical and mental labor in freezing communication hubs. Yet, the orders were signed, stamped, and distributed. The enemy perspective, as captured in these documents, shifted from a narrative of general wartime shortages to one of ruthless, calculated sacrifice. The German state was biologically cannibalizing its own support structure to keep its frontline tanks rolling for just a few more weeks. This bureaucratic cruelty quickly translated into a physical crisis for the advancing Americans. The single starving female auxiliary initially examined in the medical tent was not an anomaly. She was the vanguard of an impending avalanche. As Allied armored columns pushed deeper into the German heartland, overrunning communication centers, administrative headquarters, and supply depots, they bypassed the heavy combat units and scooped up the enemy's logistical tail. Waves of these abandoned support personnel began arriving at American processing centers. United States Army Medical Corps officers, sitting at folding field desks in hastily erected canvas tents, found themselves compiling health reports that read more like famine surveys than prisoner of war intakes. Hour by hour, the columns of captives shuffled into the holding pens. The American doctors observed a unified, horrifying physical baseline among the female auxiliaries. They exhibited the slow, shuffling gait characteristic of severe muscle wasting. Dozens collapsed silently in the processing lines, lacking the basic blood pressure required to remain standing. When American guards attempted to issue standard commands to march or form ranks, they were met with the sluggish, apathetic responses born of profound neurological exhaustion. For the medical officers tasked with assessing the incoming prisoners, the initial shock gave way to a grim diagnostic routine. They meticulously documented the plummeting body weights, the widespread edema pooling in the prisoners' ankles, and the rampant secondary infections spreading through the captive population. The doctors were forced to adapt their reporting systems in real time. Standard U.S. Army medical forms were specifically designed to document the location of shrapnel, the application of tourniquets, and the dosage of morphine. There were no designated checkboxes for systemic cellular starvation or advanced scurvy. The physicians had to write extensive narrative addendums in the margins of the intake forms, attempting to quantify a biological collapse that defied their standard military training. They were documenting the collapse of a nation, written directly on the failing bodies of the women who had been drafted to defend it. Recognizing the sheer scale of the crisis, the American medical logistics apparatus was thrown into a frantic, unprecedented scramble. The United States military possessed the most robust, deeply layered supply chain on the planet. The fabled transport networks constantly pushed mountains of materiel to the front lines. But this vast, mechanized pipeline was built exclusively for trauma. It was engineered to deliver bullets, bandages, whole blood, and high-explosive artillery shells. It was strictly not built to cure mass famine. When frontline doctors began requesting the supplies necessary to arrest profound malnutrition, they encountered intense logistical friction. The American field hospitals were overflowing with trauma kits. They had thousands of units of sterile plasma, vast stockpiles of the newly developed miracle drug penicillin, and endless rows of surgical instruments. But penicillin cannot cure starvation, and surgical steel is useless against muscle atrophy. The doctors suddenly realized their highly advanced medical arsenal was almost entirely impotent in the face of this specific biological disaster. Desperate requisitions were rapidly transmitted up the chain of command, traveling from battalion aid stations to division headquarters, and eventually to rear area quartermasters. The requests were highly unorthodox for a combat zone. Frontline physicians were urgently demanding vast quantities of easily digestible proteins, specialized intravenous electrolytes, massive shipments of powdered milk, and pure vitamin supplements. They specifically needed aggressive treatments for acute dysentery, as the prisoners' heavily degraded digestive tracts were violently rejecting whatever standard food they managed to consume. Rear echelon supply officers were initially bewildered. The logistics system was programmed to automatically push highly concentrated, dense combat meals designed to fuel healthy young men running through the mud. But feeding a standard, fat-heavy combat ration to a starving person is biologically dangerous. The American doctors were racing against time to intercept these standard food deliveries. They knew that introducing a sudden influx of dense calories to a severely malnourished digestive system would trigger refeeding syndrome, a fatal metabolic shock that rapidly depletes the body of vital electrolytes, ultimately shutting down the heart and nervous system. They had to invent a mass starvation treatment protocol in the middle of an active war zone, sourcing gentle, gradual nutrition from a supply chain that only knew how to deliver heavily processed, high-calorie combat fuel. Driven by the relentless pressure of arriving prisoners, the American medical footprint began to physically transform. The standardized field hospitals, originally designed as rapid-throughput surgical clearing stations, were hastily and fundamentally converted. The preoperative tents, normally prepped to receive bleeding casualties directly from the front, were repurposed into intensive starvation recovery wards. Canvas cots that usually held wounded infantrymen waiting for emergency surgery were now occupied by emaciated German auxiliaries, requiring slow, agonizingly careful nutritional rehabilitation. This abrupt shift in mission pushed the American medical staff to their absolute physical and psychological limits. Treating acute combat trauma is a frantic, high adrenaline process. It involves rapid decisions, immediate surgical interventions, and fast evacuation. Treating systemic starvation, by contrast, is a grinding, grueling war of attrition. It requires constant, meticulous monitoring. The doctors and nurses had to strictly measure every ounce of fluid and every gram of protein administered to the prisoners, constantly checking for the lethal cardiac arrhythmias associated with refeeding syndrome. The daily workload was staggering. Because severe malnutrition almost universally destroys the mucosal lining of the intestines, chronic violent dysentery swept through the newly converted wards. The American nurses and corpsmen found themselves trapped in a relentless cycle of cleaning soiled linens, sanitizing cots, and attempting to rehydrate patients who were rapidly losing fluids. It was exhausting, deeply unglamorous labor, performed under the roar of distant artillery and the constant drone of transport planes. The medical staff were fighting a microscopic, biological war against the lingering cruelty of the German High Command. Every successful stabilization was a hard-won victory against the enemy's calculated decision to sacrifice its own people. The American doctors, trained to repair the mechanical damage of modern weapons, were instead forced to rebuild human bodies cell by cell, relying on improvised diets, carefully diluted powdered milk, and whatever vitamins they could successfully requisition through a confused supply network. They were managing to hold the line, stabilizing the frailest of the captives through sheer willpower and relentless nursing care. But as the spring of 1945 progressed, the collapse of the Third Reich accelerated. The isolated trickle of captured support staff rapidly expanded into a torrential flood. Whole German armies began to surrender en masse. The localized crisis in the medical tents was about to be dwarfed by a continental catastrophe. The American doctors had barely figured out how to keep dozens of starving prisoners alive, only to look at the horizon and see the entire shattered remnants of the German military marching toward their lines. But as the thousands of prisoners turned into millions, the highly vaunted American supply chain hit a wall. The pristine image of an all-saving, endlessly supplied American medical intervention shattered almost instantly. Official reports from the European Theater of Operations documented a logistical network rapidly buckling under the unprecedented weight of the collapse. The sheer mass of surrendering personnel, hundreds of thousands of starving, diseased troops pouring into makeshift holding enclosures, overwhelmed even the industrial might of the United States. To prevent the total collapse of their own frontline supply chains, the Allies were forced to institute severe rationing inside the massive prisoner of war camps. The surplus calories required to biologically rehabilitate an entire ruined army simply did not exist in the devastated landscape of post-war Europe. For the American field doctors, this overarching logistical failure triggered a profound moral and professional crisis. Only days earlier, they had expressed absolute horror at the cold, bureaucratic cruelty of the German High Command, systematically abandoning its own support personnel. Now, standing in overcrowded, dysentery-plagued canvas wards, these same frontline physicians were forced to execute their own grim version of triage. With stockpiles of specialized intravenous electrolytes, powdered milk, and high-protein supplements critically depleted, doctors could no longer treat every patient. They had to walk the endless rows of canvas cots, clutching medical clipboards, making calculated, documented decisions based on sheer biological viability. They had to look at emaciated prisoners and mathematically determine who was strong enough to survive with a limited high-caloric IV and whose internal organs were already too degraded to save. The psychological weight of this assignment was devastating. Men trained to heal were now actively rationing life itself. Inside the chaotic medical tents, the vast, abstract statistics of theater-wide triage ultimately came down to the agonizing reality of a single, desperate procedure. Back in the sterile confines of the primary assessment tent, the abstract horror of a collapsing logistics network narrowed down to a single canvas cot. The American medical officer returned to the female auxiliary he had first examined. Her respiration was dangerously shallow, and her pulse barely registered against his fingertips. The intervention that followed was not a dramatic, blood-soaked surgical rescue, but a tense, agonizingly slow mathematical equation. To save her, the medical team had to navigate the lethal paradox of severe cellular starvation. The very calories required to keep her alive could easily kill her. The doctor ordered a rudimentary intravenous drip, utilizing a carefully calibrated, heavily diluted mixture of saline and glucose. This was the razor-thin margin of survival. If the corpsman pushed the glucose into her collapsed veins too quickly, her dormant pancreas would suddenly flood her system with insulin. That rapid biological reaction would violently pull essential electrolytes, specifically phosphorus, potassium, and magnesium, out of her bloodstream and into her starved cells. Her weakened, atrophied heart would simply stop. This was the terrifying, mechanical reality of refeeding syndrome. But if they administered the fluids too slowly, her already cannibalized internal organs would pass the final point of viability and systematically shut down. The medical staff engaged in a silent, unglamorous battle, fought drop by drop from a suspended glass 1.5 bottle. There were no incoming artillery shells, only the meticulous tracking of fluid volume against the second hand of a pocket watch. The doctor monitored the slow, rhythmic drip, calculating the exact caloric threshold required to restart her biological engine without flooding it. Every measured ounce of diluted powdered milk, carefully fed through a rubber tube, and every single milliliter of glucose carried the absolute weight of a life or death decision. For hours, the outcome hovered in a clinical purgatory. It was a microscopic war of attrition, waged entirely inside the veins of a discarded enemy soldier. When her vital signs finally began to stabilize, when the profound bradycardia yielded to a slightly stronger, steadier rhythm, there was no celebration. The doctor simply noted the shifting metrics in pencil on a standard U.S. Army intake form. The outcome of this quiet struggle was secured within a simple, unremarkable medical file. Yet those few hastily scribbled pages held the definitive, undeniable truth of the war's conclusion. Stepping back from the immediate urgency of the intravenous drip, that single, pencil-smudged U.S. Army medical report becomes much more than a routine patient record. It stands as a stark, meticulously documented microhistory of the collapse of the Third Reich. For decades, the German military apparatus has been heavily mythologized as a perfectly disciplined, highly mechanized juggernaut of tactical brilliance. But the clinical data captured on this intake form violently strips away that enduring illusion. It proves that the ultimate defeat of a nation is rarely decided purely by being outmaneuvered on a grand strategic map. Warfare fundamentally ends when logistics fail, when trains stop moving, and desperate quartermasters begin mathematically sacrificing their own support personnel to buy a few extra weeks of combat. The grand ambitions of an empire rapidly dissolve into nothing more than failing human biology. We typically study the Second World War through sweeping arrows on tactical maps, analyzing the movements of massive panzer armies and bomber fleets. But this episode forces us to confront a much more fragile, unforgiving reality. The mighty war machine was ultimately dismantled by the physical boundaries of the human body, the collapse of basic supply chains, and the grim, calculated reality of medical triage. The vast, mechanized theater of global conflict had finally shrunk to its most elemental form, isolated entirely within the dimensions of a single canvas hospital cot. In the end, the collapse of the Third Reich was not defined by a final, cinematic gunshot echoing across a ruined capital. Instead, the European war ground to its bitter conclusion in the suffocating silence of these canvas tents. It ended with the slow, desperate drip of a glass 1.5 bottle and the quiet, exhausted focus of an American field doctor simply trying to keep a starving enemy alive for one more hour.